Good morning, good morning, good morning. I hope you're all well. So I'm coming to STA members this morning to talk about exercise prescription for shoulder pain. I know a few of you are really keen to have this seminar on shoulder pain. So I'm first of all, you'll notice that Gary is not here today. He has a few technical issues, and I think we're going to be seeing Gary on Friday instead. So I'll just crack on my own, and we will go through the webinar today. So shoulder pain, and first of all, a bit about my experience with shoulder pain. I'm a physiotherapist and osteopath, and I've done some seminars for the STA previously. Most notably, we did some at Therapy Expo, and I've been a keen supporter of the STA for a few years now. And Gary's clearly doing a fantastic job during extremely difficult times. I hope you're staying well and positive. It is very hard being in lockdown. Hopefully you're all okay from a health perspective, and just stay strong, hang in there. I think we're starting to see some light at the end of the tunnel. So hopefully things will be going back to normal very soon. So in the meantime, we have online webinars to give some some education, at least. If you're not able to go out there and work, you might as well make it a learning day, right? So shoulder rehab. My experience with shoulders is I love shoulders. I absolutely adore the treatment of shoulders. They can be so challenging. I think that's why I like them so much. We see them all the time. They're just so common. Shoulder pain prevalence equates to about 2.4% of GP appointments. There are over 300 million GP appointments a year. So that is quite a lot of shoulder pain. Now, as sports therapists, you may see two types of shoulder pain, or what we call shoulder pain. You may see the shoulder pain that comes across the top of your shoulders here, and you may see the actual glenohumeral or acromioclavicular joint type shoulder pain. So we'll kind of cover both and discuss each one with the focus mostly on problems actually at the glenohumeral or acromioclavicular joint. So let's just make my screen a little bit bigger, and hopefully you can all see that. Right. So shoulder pain is pretty misunderstood, and with research now coming out, there's even questions about the research which we were looking at 3 or 4 years ago, which questioned research for many years before. Shoulder pain is very confusing. The shoulder is a very complicated joint. It's full of muscles and small muscles and ligaments and tendons that can become damaged. And there's some different camps believe different things about shoulder pain and the causes. And we'll look at a few of those ideas. One of the things we do tend to find is sort of frozen shoulder is sort of quite often overdiagnosed. Now, I know that you guys may not be making diagnoses, and some of you it may be within your scope of practice, but I suspect for the majority of you won't be making a diagnosis. But that's fine, because you can still understand the shoulder and have a good idea what's going on, which will help you guide your rehabilitation for the shoulder. So let's familiarize ourselves with a little bit of anatomy. So we've got the head of your humerus here. We've got the glenoid, which is the socket, which you can just see here. Okay, around the glenoid we have a labrum, which is when I describe the labrum, I kind of describe it like a golf tee, where you put a golf ball on a golf tee and there's a rim around the edge, and that rim just helps provide a little bit more stability for the shoulder, because the shoulders, if you look at an actual glenoid cavity, it's actually quite shallow. It's quite flat, and that flatness of the socket allows lots and lots of movement of the humerus and upper arm. And So that's really good, but actually there does need to be some stability to keep the shoulder in place, and hence you have a labrum. The labrum provides that sort of extra slight depth around the shoulder and prevents dislocations, along with ligaments and some of the muscles. So we've got a very important muscle that runs underneath the acromioclavicular joint. So here's the acromioclavicular joint. It's the joint between the clavicle and the acromion on the scapula. This joint is a very big source of shoulder problems, much more so than the actual shoulder joint. We see most problems happening at the acromioclavicular joint, and they are often degenerative related. So I'll come into more detail about that in a minute. Under the acromioclavicular joint, we've got a very important rotator cuff tendon. You'll all have heard of it. It's called supraspinatus, and it sits just above the spine of the scapula. There's a small groove. There's a small sort of pocket where it sits above the spine of the scap, and then the tendon comes in and joins onto the humeral head. This tendon is around about, if there's a tendon problem in the shoulder, it's usually the supraspinatus. I think it's about 80 or 85% of prevalence of tendon issues are related to the supraspinatus. And we've got the clavicle, of course, across the front. And you've got other smaller joints around the shoulder, like the scapulothoracic joint, for example, and the sternoclavicular joint. But we'll focus mostly on the AC joint and the GH joint, or ACJ and GHJ, as we sometimes like to call them. Good. So shoulder pathology, we'll touch on this just so you've got an idea. It's worth having an idea. Like I say, you won't be diagnosing, but typical shoulder pathologies we see, well, we often look at the acromioclavicular joint as a source of shoulder pain. So as I mentioned earlier, that AC joint tends to represent the majority of shoulder problems. Why is that? Well, there's a number of reasons. They can be related to posture. They can be related to the way we put pressure through our upper limb. And we know through extensive MRI scanning that problems at the GH joint are far rarer. Now, I've probably myself looked at in the region of 500 MRI shoulders. I'm a bit of I like to think of myself as a little bit of a pro at seeing shoulder patients. I've been specializing in shoulders for quite a long time. And I work very closely with shoulder surgeons. So one of the things that's interesting is you rarely see osteoarthritis of the glenohumeral joint. And frozen shoulder is not as common as people think. So when we see osteoarthritis of the shoulder, we typically see it at the AC joint. For some reason, the AC joint, maybe it's because of our way we use our arms, it tends to get, the force tends to dissipate more into the AC joint. And we see hypertrophy or thickening of the AC joint. So when there's degenerative change, it goes to the AC joint much more commonly. And then you get osteophyte formation around the AC joint. So when a joint becomes degenerative, it tends to hypertrophy or get bigger. You see this in knees as well. We're doing our knees seminar on Friday, but with an osteoarthritic knee, it tends to be bigger. It gets swollen and there's bone laid down. And that happens around the AC joint. And when that happens, the tendon underneath the joint, the supraspinatus tendon, can get scratched, irritated, impinged, pinched, whatever you like to term it. We often use the term impingement, and that can cause a problem. So shoulder impingement, whether you call it impingement, most people call it shoulder impingement. It's not technically a diagnosis, it's a syndrome. So impingement is that the tendon has become impinged against something, and we're starting to commonly call this subacromial pain syndrome. But many people in the camp still refer to it as shoulder impingement. What is impingement? It's just the tendons getting pinched under the acromion, usually due to degenerative change at the AC joint. Sometimes it can be because the acromion is slightly hooked. So that's a flat acromion. That's a grade 1 hook, grade 2 hook, grade 3 hooked acromion. And that then decreases the space under the acromion, which we call the subacromial space. There's also a bursa that sits under there. And that is called the subacromial bursa. If you have an irritation of the tendon, you often get an irritation of the bursa because it protects the tendon from the bone, and the bursa can become swollen, so you have bursitis. And if you've heard the term bursitis in the shoulder, that's what it refers to. Excuse me, my Skype is ringing. I should have switched it off. Right, so the tendon can become irritated, inflamed. If it becomes inflamed, it often forms something called supraspinatus tendinitis, or tendinitis of the shoulder. And you can get tears in the shoulder as well. So when you hear of a rotator cuff tear, what you're hearing is most commonly it's a tear to the supraspinatus tendon. Not always. There are 4 rotator cuffs, but it's the supraspinatus that tends to get hit the hardest. That supraspinatus gradually gets irritated under the AC joint, and the first thing we'll see on an MRI scan is you'll see fraying at the superior edge of the supraspinatus. The fraying then becomes slightly larger, and eventually you end up with partial thickness tear. So partial thickness tear is a tear that goes partially through the width of the tendon, then a full thickness tear, and then you can have a rupture where the tendon actually completely goes. It's a serious problem. May often require surgery depending on the age of the patient. Difficult to repair surgically. Interestingly, when you look at shoulder surgeries, most shoulder surgeries are decompression. So they go in, they trim underneath the AC joint and trim around the shoulder, and that frees up space for the supraspinatus tendon. There's very limited evidence on the viability of shoulder surgeries, but we do find that there is a place for them when all else fails. So what can you do to help your patients? Well, lots and lots. And there's a huge place for actually therapy treatment, sports therapy treatment, physiotherapy treatment, manual therapy, osteopathy, chiropractic. I think all of these professions can help shoulder pain significantly. And we'll talk a little bit about that. So the other type of shoulder problems occur at the glenohumeral joint. So things like dislocations and labral tears and frozen shoulder. And frozen shoulder is interesting. So we'll talk about that in a second. But there's also other shoulder pathologies, and the nasty ones that we don't want to see often are things like tumors. I've never seen a tumor in the shoulder, fortunately, touch wood. We sometimes see things like polymyalgia rheumatica, which is where patients get bilateral shoulder pain as well as other body pains. And you don't really need to worry about that. I think the thing to do is, if you spot something that doesn't look right, it's very, very easy to refer them to a colleague. You can upscale it, refer them to physio or osteopath or other medical professional, such as a GP. If it doesn't look right, don't treat it. If you're not sure, chances are, if it's at that stage, they'll probably be under the care of their GP already. Good. So frozen shoulder, what is it? Well, it's a shrinking or contraction around the glenohumeral joint. Not particularly common. Back in the day, we used to say it was idiopathic. So when I learned about it back in, God, when was this? Back in 2000, we used to be told that most frozen shoulders are idiopathic, so they just happen for no reason. We see one or two. Actually, there's the odd one that reaches in the back of a car seat, or whatever, and then they end up with a frozen shoulder. I mean, mostly frozen shoulders occur after trauma. So typically, I better switch my Skype off in a minute. Mostly they occur after trauma. So they occur following skiing injuries, following dislocations, following bad falls, and after trauma, following shoulder surgery. Big complication after shoulder surgery is frozen shoulder. Why? Well, because the shoulder's been operated on. There's a lot of bleeding and inflammation and irritation. And you often, if you've had a rotator cuff repair, you're often in a sling for up to 6 weeks. Well, 6 weeks not moving your arm very much, you're going to end up with some form of frozen shoulder. And that's a real problem. So we see that a lot. And we have to manage that with rehab and exercises. So anyway, point is, frozen shoulder is not that common, and we don't typically diagnose it that often, but it does still present. Shoulder impingement is much more common, so sometimes called subacromial pain syndrome. Like I said, it's an umbrella term, so it's a syndrome. So it's not a diagnosis as such, but it can refer to the AC joint, the bursa, the subacromial bursa, the rotator cuff tendon, etc. Good. So 3 questions we typically ask our patients are you able to lift your arm above your head? And you'll find a lot of shoulder patients really struggle with getting that flexion. Number 2, are you able to reach for your bra strap? So a lot of patients as well really have trouble reaching behind their back. Guys, we ask, are you having trouble tucking your shirt and your trousers? Or ladies, are you able to reach your bra strap? And are you able to sleep on that side? So typically we find people with shoulder pain, and especially impingement type syndromes, really struggle with lifting their arm above their head, reaching behind their back and sleeping on their side. And that's fairly a good indication that they probably have some kind of shoulder impingement going on. Of course, it can cover other things as well, but that's when we do an examination. And like I say, you don't need to worry about the shoulder diagnosis, but just having an idea, I think, is useful. So shoulder pain management. Well, what are we going to recommend to our clients? I think the first thing we typically might try and do is let's try and reduce some of their pain and inflammation. Let's try and make them more comfortable. So we'd probably prescribe some ice or heat. Now, there's always big debate, and I always talk about it, is should you ice it, should you heat it? You know what? I'd say what works for you and what works for your patient. Some people prefer ice, some people prefer heat, some find ice more useful, some find heat more useful. I think ice is quite good for pain management, and possibly reducing inflammation, whereas heat's great to help mobility. So actually both can be useful. And if you're not sure, the old term of contrast bathing can be very, very, very good. The combination of ice and heat. Typically, in the early stages, I recommend ice, and in the latter stages, I recommend heat. But often I recommend both, and see what works for the patient. Ice and heat are good; they're natural, and it's good to give the patient something to do. It's good to give them control so they can manage their pain. Of course, GP may have prescribed anti-inflammatories, and there's a place for anti-inflammatories. And the second thing we might like to do is to just try and get some movement back to the shoulder. So generally speaking, when you improve movement at the shoulder joint, things do tend to get better. They tend to start settling down. The shoulder likes to be mobile. It's a very mobile joint. It doesn't like to be stiff. So let's get that shoulder moving. So I'm going to switch my screen and come on to some exercise prescription. So at the moment, we're very limited with what we can do. So virtually all of our work is actually video and telephone consultations, if not 100%. And most shoulder pain is not an emergency or urgent. So it's very unlikely that you'll be seeing any shoulder pain patients. I believe actually probably you guys are shut at the moment. But at some point, I guess when you do reopen, I know a lot of practitioners are talking about reopening. Just out of interest, our sports therapist actually messaged me last night and said she's keen to come back to work, and when can they come back? I don't think it's going to be too long, but obviously we'll wait for the official guidance from from government or STA, who will feedback. So we won't be seeing any face-to-faces, but there's a good opportunity to do some shoulder online rehab. This is Rehab My Patient. This is my software. This is not a sales pitch, but I'm going to use my software to demonstrate how I'm going to prescribe some exercises, and it's very good for learning actually. So we've got our patient list here. Let's just go to my test patient and let's start prescribing some exercises. So I think probably let's start with, we'll go to shoulder category. Let's start with some ice on the shoulder and some advice about sleeping position, and let's give them an advice sheet. So they may have already been diagnosed with shoulder impingement or with frozen shoulder, whatever it is, or whatever condition, but we can always give them an advice sheet because often patients are not given the actual written advice. So it's good for them to give a common sense advice sheet that they can read. So let's find our advice sheet. Let's call it shoulder impingement, and let's add the advice sheet, and let's give them a very simple shoulder mobility exercise. So I love the pendulum. I think it's a great exercise. It's really good exercise, but often done wrong. So it's well worth demonstrating this exercise to your patients. If you haven't got access to Rehab, we have free access to Rehab on our platform. So you can go to click Rehab at the top and do an online consultation and demonstrate the exercise for your patient. So the key thing about this exercise is you really want to lean over so the shoulder hangs down. A lot of people try and do the exercise too actively. So they often start sort of swinging the shoulder. They're sort of leaning, but they're swinging it like this. And this is incorrect. We really want to hang down and just let the shoulder swing on its own momentum in quite small circles to start with. Okay, and when done like that, it ends up being a very good way to passively. It's not completely passive, of course, but it ends up being a very good way to passively mobilize a stiff shoulder, or as much passively as possible. Good. So I'll probably get my patient started on that. So we'll add that shoulder rehab week 1. Let's just change the order of that and continue. Put in your sets and reps. Typically I hold ice for 10 minutes and do it twice a day. I typically do the pendulum for about 1 minute up to 5 times a day. We'll save that and email that to our patient. Good, that's done. So now let's go on to sort of a little bit more progressive. So let's assume we're starting to get the inflammation out and the pain is reducing, but we still want to get more movement. So a lot of these people will have very stiff shoulders. So we want to get the movement back to the shoulder. Well, how do we get the movement back? Well, we can mobilize, we can massage, we can stretch around the shoulder. Absolutely, and you can do that. At the moment, that's not possible. So we would be more likely to prescribe some shoulder exercises. Let's give some passive, gentle shoulder exercises. This one's very good. So a passive arm lift. So they're going to support their arm and gently lift their arm up. Okay, very good for increasing range of movement. And if they're limited, so if they're at this angle, doing this every day, they'll gradually go higher and higher as they get used to the exercises and challenge the shoulder. I love the rock the baby because it's a good pendulum exercise. Abduction exercise. So we just support the arm and move the arm into abduction gently. So that increases abduction because we know that abduction tends to be limited with impingement patients. And add rock the baby. We don't need our advice sheet anymore. Let's give a gentle internal rotation exercise. So one such as the bra strap exercise is good. They don't need to go all the way back there, but they can just start to go gently behind their back, and they use the other hand to assist going behind their back. So you reach gently behind your back, take the arm, and just gently lift up through the back. This is a little bit slow actually because we're live streaming, but here's the exercise now. It might be a little bit jittery because of the video. Good. Okay. So we've got our exercise program. That's week 2. So let's give that to week 2. Now, you see how I'm not sending so many exercises. I'm really just prescribing 3 or 4 exercises per plan. Now, why am I doing that? So I believe it's a big error that therapists make is they try and put 15, 20 exercises on one sheet. you know what, patients just typically don't do that. They don't do those exercises. And also, you know what, if you give exercises slowly, you can actually monitor them. So you can do the first 4, you can see if any are sore or aggravating it. If you've given a program of 20 exercises, it's almost impossible to know what helped, what worked, what didn't work. And so we give 3 or 4 exercises per program so we can monitor it, and then we progress our patients that way so we can keep a handle of it. Good. So we'll save that and email that to my patient. Once we start getting some movement back, we probably want to start working a little bit on some stability and strengthening to the shoulder. Shoulder is such a key joint for stability. It's really important for stability. And so we might just go to our stability category under shoulder and look at some of the stabilizing exercises. Things like a prayer push or anything in a 4-point position is very good for shoulder stability. Often when we talk about shoulder stability, we also talk about scapular stability as well. So things like retraction of the scapula, strengthening the scapular muscles such as the rhomboid muscles, it can be very useful. So stabilities tend to be a weight shift is a very good early stage stability exercise where we simply put some weight through our hands and we just gently lean onto one side. Ball exercises, if they've got a Swiss ball, are really, really excellent for stability. And this is the sort of thing we might do with our patients actually live in a rehab session. And the arm pushes against a wall on a ball. They don't have to use a goofball, they can use a football or a tennis ball. This is a great exercise. And when I do live teaching sessions, I get patients, I get attendees to actually push against themselves and just to wobble the ball slightly. You can really feel the muscles stabilize in the shoulder. So we'll add these exercises here. Let's add this one, and let's add a standing stabilization wall press. And this is part of our stability program to the shoulder. Moving on from that, we want to start building up some strength. So when they're ready and able and the pain is controllable, let's build strength to the shoulder. How do we strengthen the shoulder? Well, we typically look at rotator cuff strengthening. And we've got a strengthening category here. So that might involve some dumbbells, it might involve some fair bands, but there's lots of ways to do these exercises. Generally speaking, we often put the arm through rotation, or in this case, scaption. So this is called draw the sword. It's a great exercise when they've got range of movement back. Obviously, if they can't reach above the head, we wouldn't be doing this exercise at this stage. And it's a strengthening exercise for the shoulder. It improves strength in the anterior deltoid, mid deltoid, and the rotator cuff muscles. So these are the sort of exercise I might want to give. There's also isometric exercises like door exercises here as well, which are very useful. Pushes against the door into internal rotation, external rotation, flexion, and extension. And that just helps to build some gentle strength back in the shoulder as well. And after strengthening them, really we want to start getting our patients a little bit more functional. So we'd probably look at doing some, we might do some band work, some fair band exercises, and it really depends. Functional rehab depends on what they want to do. They might want to go swimming. So we might try to replicate or challenge them in those movements that they need to do. They might want to go hiking. So they may just need to have some pressure going through the shoulder to use a hiking stick. They may be wanting to go back playing tennis. So we might be replicating an overhead movement or a throw-in movement. And we need to kind of replicate the types of movements that they need to do. So often when you functionally rehab, you rehab in different planes, different directions, different angles, if you like. And when we're in sporting situations, nothing is really one-dimensional, or very rarely. It's actually really sort of completely three-dimensional. Everything kind of everything sort of moves in different directions, and we're constantly changing direction. So we have to be ready for rehabbing the shoulder in different positions and different directions and different angles so that it can actually cope with doing the physical demands of a particular sport or getting back to normal. Good. So that's shoulder rehab in a nutshell, and give some ideas. Now, I just want to progress on to neck rehab a bit. So often patients come in with this tightness across the shoulders and neck, and we see that all the time. Of course we do. And you guys will see it even more than I see it. And how do we get rid of this really tight shoulders? Well, I mean, of course, there's lots of strategies, and we always take a multi-faceted approach at this. We probably want to look at lifestyle, so we might want to address the stress levels. We probably want to look at their ergonomics, their workstation position. So let's just go to our ergonomics exercise and let's just give them a computer setup, especially relevant at the moment with lots of people working at home on laptops and with bad computer setups. So we can give some ideas on the correct way to hold the screen, to use their screen, etc. Okay. And then we might want to give some stretches. So typical stretches might be a levator scapulae stretch. So here's a couple of levator scap stretches. Other stretches might be trapezius stretches, so upper trapezius stretches, such as a neck side flexion stretch. Okay. Or a progressive side flexion stretch where we just apply a little bit of distraction to the arm or traction to the arm and just side flex the neck to stretch the upper trapezius. And we might want to do a sternocleidomastoid stretch if we're very short and tight for the front. And in some cases, actually, we might even want to strengthen those areas as well. So we might even want to do some upper trapezius strengthening. It depends on what your examination finds, whether you stretch or strengthen, but both are possible. If you wanted to strengthen the upper trapezius, of course, we could do some shoulder shrugs with dumbbells, or some arm lifts prone. Very good. But let's say we do want to stretch. I mean, typically when they're really tight for the shoulders, we want to look at what's creating that tightness or stiffness. And generally speaking, improving posture can make a big difference. So this is where the advice and management come in. We want to try and sort of open up the pectoral area because we tend to all be a little bit anterior based. We're using phones and things in front of us, but we're not really opening these shoulders up. So we might want to stretch with a pec stretch. And if we stretch with a pec stretch, we might want to also strengthen the scapular stabilizers, such as the rhomboids. So we might do some retraction exercises on the shoulder for the rhomboids. A dart, pren cobra, is a very good scapular strengthening exercise, very good for posture. So people will typically lie on their front, turn their arms behind them, put their arms behind them, and squeeze the shoulder blades together and gently lift the neck. This is progressive, so there's actually a more progressive one from this. Here we see it here. And this helps strengthen from the erector spinae to the thoracic erector spinae, from cervical to thoracic erector spinae, tricep, rhomboids, even lumbar erector spinae. In fact, it really helps stabilize the whole posterior chain. So scapular retraction is very, very useful, and can definitely help our patients too. Good. Well, that's a brief look into shoulder rehab. I usually do a one-day course on this. In fact, actually can go much, much deeper than that as well. And this is really just touching the surface. I completely appreciate that this may be very foreign to some of you. And I would say, don't worry about that. I know on Monday someone was asking, are we able to prescribe exercises? Well, I always say to people, I think exercise is such a fundamental part of living that actually most people do have some knowledge of exercise. You've got to work out whether it's within your scope of practice. You will be insured to prescribe exercise, of course, but is it? Have you been trained in it? And if you're not sure, then start simply. You give simple exercises like passive and gentle ones, and you don't have to go on to complicated strengthening, machines and whatnot. You just start slowly. And I do really recommend you try exercise prescription because it is so useful. It's so important, and it's a really good add-on to your therapy side of things, especially if you can't see your patients. So that concludes my talk. I'm going to open it up to any questions. So I'm going to just go on the Facebook page now and just see if there's any questions that have popped up. So let's just bear with me while I go on to the Facebook. This might mess up my system actually if I do this. I'm not sure. I've not done this before. Right. So just see if there's any. If you've got any questions, feel free to ask them, and I hopefully will be able to reply. Lots of good mornings. Great. Okay. So if there's no questions, if you want to post them in the comments, I'll probably keep an eye on it so I can see that later. But if there's no other questions, then I will say good to speak to you. Good luck with your exercise prescription. I'm back on Friday morning at 10 a.m. to do another talk for you. Really happy to just to speak to you and to share a little bit of knowledge. Apologies if you all know the stuff. It's always difficult when you can't really see your audience. But thanks very much. Enjoy your days. Stay well. Stay healthy. Keep your spirits up if you can. And I'll see you on Friday. Friday, 10 a.m. Take care.